Before I introduce our speaker today, just a reminder to please leave your questions to the end of the presentation and enter them in the chat. As well, please let us know that you were present at today's rounds by answering a brief survey that will be sent to you immediately after the medical grand rounds. So today's presentation is being brought to us by the Division of Gastroenterology, and it is a great pleasure for me to introduce our guest speaker today, Dr. Giada Sebastiani, who is an associate professor of medicine at McGill University and a clinician scientist at the MUHC RI. Dr. Sebastiani received a medical degree specializing in internal medicine at the University of Padua in Italy. She is trained in clinical and basic research at Harvard Medical School and University College London, University of Bordeaux, and Lady Davis Institute for Medical Research here in Montreal. Her work focuses on fatty liver disease, liver fibrosis, and non-invasive diagnostic tools in liver disease with a current focus on at-risk population. She is the author of over 118 articles in peer-reviewed journals, including and not limited to Lancet, Digital Health, Gastroenterology, and Hepatology. She has over 13 book chapters, 194 conference publications at national and international congresses, and she is the founding and steering committee member of the Canadian NASH Network and panel member of the Canadian Models Consensus on Models of Care in NAFLD of the International Liver Foundation. She has been invited as a speaker in 80 international congresses and universities, including European, Asian Pacific, Mexican, Italian, and Canadian associations for the study of the liver. She was recently awarded the prestigious Senior Clinical Research Salary Award from the Fonds de Recherche de Santé Québec, and her research focus program is funded by the Canadian Institute of Health Research, the Fonds de Recherche de Santé Québec, and the Canadian Donation and Transplantation Research Program, and the CIHR Canadian HIV Trials Network. So after all that, we're very much looking forward to your talk, Dr. Giada Sebastiani. The floor is yours. Thanks for being here today.
Thank you very much, Nadia, for the very, very kind introduction. And it's always a pleasure actually to present at the medical rounds to our colleagues. So it's actually an honor. So thank you very much for inviting me. And as you said very nicely, the presentation will be on fatty liver disease. So these are my disclosures. And also I want to underline that part of the slides are developed by myself. The ones that you see, clinical care options program, are actually developed by myself for an NAFLD program. And you are actually welcome, if you are interested in more, to look into this program where I developed some more information on the current management of the liver disease that we are going to talk today about. So the learning objectives for these lectures are to understand epidemiology and pathogenesis of fatty liver, to be familiar with current diagnostic strategies for fatty liver disease, and integrate therapeutic principles of fatty liver into clinical practice. So we will go through definition and epidemiology, pathogenesis, diagnosis and impact of liver fibrosis, and principle of therapy. So let's start with the definition of the disease. What is fatty liver actually? First of all, fatty liver has actually a global prevalence today at 25.24%, which makes it the most frequent liver disease at the global level, as you can see here with some geographical differences. But overall, the global prevalence is basically that 1 in 4 adults are affected by the disease. And NASH represents, in fact, now the #1 indication for liver transplant in people aged less than 50 years old and in women. And this actually has surpassed other etiologies of liver disease as primary indication for liver transplant compared to the past. And there is a projection that in the next basically 8 years, it will become the #1 indication for liver transplant at the global level. So what is NAFLD? NAFLD is actually defined as a fatty liver overcharge, basically overcharge or overload of fat into the liver, affecting at least 5% of the hepatocytes. And there are two kinds of different fatty liver disease. NAFLD, which is non-alcoholic fatty liver disease, and secondary causes of fatty liver disease, such as alcohol, drugs, and hereditary disorders. But NAFLD is basically defined by the presence of this steatosis, of these steatotic hepatocytes in presence, in most of the cases, of metabolic abnormalities, which are likely mostly associated with NAFLD pathogenesis, such as obesity, diabetes, hypertension, and dyslipidemia. And basically, under the NAFLD umbrella term, there are two entities that are different, both in terms of diagnostic implication, but also and especially for prognostication. The first one is NAFLD, also defined as simple steatosis or fatty liver, where basically there is a liver which is overloaded with the steatotic hepatocytes in absence of inflammation, while NASH, which is also called non-alcoholic steatohepatitis, is characterized by steatosis, so by fatty liver, but also two other important features, which are inflammation and hepatocyte ballooning, which will eventually lead to liver fibrosis, liver cirrhosis, and end-stage complications related to liver disease. And indeed, if you can see here, there is also a new tendency of a couple of years now to try to change the nomenclature from NAFLD to MAFLD. Why? Because NAFLD is mostly diagnosis of exclusion, as we said. So it has basically to be steatosis in absence of hepatitis C, hepatitis B, and alcohol. While now, in the last couple of years, there are some movement, especially from the European side, to try to change this nomenclature to MAFLD, metabolic associated fatty liver disease, which is more a positive diagnosis, but for the moment, basically caused where there is more emphasis on the really etiological factors causing fatty liver disease, which are metabolic comorbidities. However, for the moment, there is still not clear if this will change at some point, or for the moment, we will remain to the definition of NAFLD. So what is NAFLD? NAFLD, in terms of the continuum, is characterized in terms of the natural history. You can see here, you start with from a normal liver, and then basically you have steatotic liver, or NAFL, as we defined before. So in absence of alcoholic consumption or secondary causing of steatosis. And then from this, we can actually go to steatohepatitis or NASH, where you have fatty liver with significant inflammation and hepatocyte ballooning, which will eventually lead to fibrosis, cirrhosis, and end-stage complications. So in terms of what is the epidemiology and the current prevalence of the different stages of NAFLD in the population, if we see from the data from the United States, probably we know that about 30% of the general adult population is affected by NAFL, and 10 to 30% of these are affected by NASH, and 20–30% of these patients will actually develop end-stage liver disease, including liver cirrhosis and complications. If we turn this to a possible projected prevalence to Canada, probably a little bit less the prevalence of steatosis at 25%, but we ended up having about almost 8 million Canadians affected by the disease, 2 million with NASH, and 300,000 with liver cirrhosis caused by this disease. And in this study that we performed as Canadian NASH Network, we went even beyond, and we modeled the burden of the liver disease in Canada within the next 10 years, until 2030, basically, basing ourselves on the use of Markov model. And if you can see here, in the next 10 years, basically, we will have a projection of increase in the prevalent cases of NAFLD of 20%. Prevalent NASH cases will increase by 35% in Canada, but most worrisome, unfortunately, this modeling shows us that the prevalence of a compensated cirrhosis NAFLD cases will almost double, as it will double prevalent decompensated cirrhosis cases, hepatocellular carcinoma, and liver transplant cases due to NAFLD. So there is really a tsunami wave that is coming upon us in the next 10 years if anything is done to stop this basically trend. And I think that one of the most important things in this sense is awareness. In this paper that we recently published, again as Canadian NASH Network, we basically surveyed 171 healthcare professionals, including primary care physicians, specialists, and nurses. And unfortunately, the knowledge around NAFLD is still only suboptimal. For example, a significant percentage of these healthcare professionals thinks that the prevalence of NAFLD is much less than it actually is in Canada, and a significant proportion also of the healthcare professionals consider themselves not familiar at all or only somewhat familiar with NASH and NAFLD. So awareness is one of the most important things to do. And this is not a situation which is unique to Canada. There are many other surveys similar to ours that show that across the globe, there is really a lack of awareness about this condition. Because of that, the NAFLD Consensus Consortium that I'm part of, we actually published now in January 2022, a consensus statement from the International Liver Foundation, where we want really to advance the global public health agenda for NAFLD, because until now, NAFLD has received little attention from the global public health community, and health system and public health responses to NAFLD have been really weak and fragmented overall. So there is really a lot of work that we are trying to do at the national and also at the global level on this condition. So now let's move to the pathogenesis of this condition. NAFLD is a classical multifactorial disease where environmental and genetic factors strike to determine the natural history and the pathogenesis of the disease. And these include, for example, sedentary lifestyles, snacking, fast food, saturated fats, the consumption of processed red meat, hepatotoxic drug, and gut dysbiosis. There is also a genetic predisposition that is clearly identified in NAFLD NASH, and the strongest genetic predictor of severity of the disease is some mutation and some allele mutation is the PNLPA3 patatin-like gene. Basically, this causes more severe disease in patients who are of Hispanic origin compared to Caucasian and compared to Black. So there is indeed a genetic predisposition, but environmental factors play also a major role in this disease. And here, overall, you can see the pathogenesis of the disease from stress hepatocytes to hepatic lipotoxicity, inflammation, and cirrhosis. And basically from excess delivery of dietary fat and excess production of fat from sugars, you actually develop insulin-resistant adipose tissue with increased lipolysis and adipose cytokines and reduction in adiponectin, and then on causing insulin resistance, oxidative stress, so development of steatosis, active steatohepatitis or NASH, and then fibrosis and cirrhosis and end-stage complications. So in this setting, NAFLD is classically associated with some at-risk populations that have been clearly identified in the past years. And for sure, the component of the metabolic syndrome are driving most of this pathogenesis. For example, as you can see here, the prevalence of NAFLD, NASH, fibrosis, and cirrhosis are higher in patients with obesity, patients with type 2 diabetes, but even in patients with hyperlipidemia, for example, compared to the general population. Beyond these populations at high risk for NAFLD, in our institution, the hepatology team is actually working a lot also on other at-risk population in conjunction with the team from the Chronic Viral Illness Service. We actually developed one of the largest cohort in the world investigating fatty liver in people with HIV, and we found in several publications that NAFLD is more frequent, more severe in people with HIV. And these are really data that we have been pioneering in this topic. And just to show again how this condition is classically multidisciplinary and targets many populations. Also in the gastroenterology team with Dr. Bessie Sao, Dr. Afif, Dr. Bitton, we have studied NAFLD in a large population of patients with inflammatory bowel disease, and we found that also in this population, NAFLD is particularly frequent, probably because of the use of also medications and also other specific factors, for example, gut dysbiosis and oxidative stress. And finally, with this condition, we also liaisoned with the gynecology team and Dr. Krishnamurti, and we have found also that the prevalence of NAFLD is particularly high in young females with polycystic ovary syndrome, with an odd ratio of 2.49 reported for NAFLD compared to controls. So, but going back to what is for sure the most important, one of the most and probably the strongest predictor of advanced fibrosis is type 2 diabetes. And that's why there is a very good collaboration with our endocrinology doctors and colleagues, which is fantastic. And basically, type 2 diabetes is really the strongest predictor of advanced fibrosis with an odd ratio at 18.20, followed by BMI. So really, I suspicion in case of type 2 diabetes for patients with NAFLD, particularly because diabetes is the #1 predictor for advanced fibrosis. And we will see together what advanced fibrosis means in terms of prognostication. And the association between type 2 diabetes and NASH is so strong that I actually call it the perfect storm. Like the George Clooney movie, really, there is this tidal wave coming because the presence of type 2 diabetes is an independent risk factor for development of NASH. It increases the rate of NASH progression, and there are also higher rates of hepatocellular carcinoma and cirrhosis in patients with type 2 diabetes. But on the other way around, it's really bidirectional. The presence of NASH is an independent risk factor for development of type 2 diabetes, which means that patients with NASH who don't have type 2 diabetes today, they have a much higher risk of developing it during their lifespan. The presence of NASH also worsens hyperinsulinemia, insulin resistance, and dyslipidemia in patients with type 2 diabetes. And in this very nice study that was published very recently from Japan, again, it was confirmed this is important bidirectional association between type 2 diabetes and fatty liver disease. In over 2,500 patients with type 2 diabetes from a single center in Japan, followed for 2 years, the researchers found that remission of type 2 diabetes was less common in people with fatty liver detected by ultrasound, and they also found an improvement of fatty liver independently associated with type 2 diabetes remission, so clearly showing this bidirectional association. Very nice, very elegant study. Beyond diabetes, I think it's very important for us also as International Liver Foundation. One of the mandates that we have is also to to try to widespread the concept that NAFLD is not just about the liver, but it is a multi-system disease, largely unknown across other specialties which are actually affected by this condition. NAFLD is, in fact, is a multi-system disease based on a chronic inflammatory milieu, where you can see here a myriad of conditions that have been found to be associated in an independent fashion to NAFLD NASH. And that's why this condition usually require a variety of stakeholders in the treatment, especially of the advanced phases, like when there is NASH with significant or with advanced fibrosis. In fact, the concept of NASH and NAFLD as a multi-system disease is clearly shown by the fact that the major cause of death is actually not liver, but is cardiovascular disease. The number one cause of death is cardiovascular disease, followed by liver. And the third is actually malignancy. And we speak about extrahepatic malignancies, not hepatocellular carcinoma. For example, several studies have shown that hematologic conditions are more frequent, breast cancer is more frequent, colorectal cancer is most frequent, and pancreas is more frequent. Overall, because of the concept of NAFLD as a multi-system disease, the European Association for the Study of the Liver has actually in its own guidelines stated that cardiovascular complications frequently dictate the outcome on NAFLD, and screening of cardiovascular system is mandatory in all persons, at least by detailed risk factor assessment. So now we move to another important section related to NAFLD, which is the diagnosis of the condition and the impact also of liver fibrosis. So why we need to look for fibrosis in these patients. So NASH, as we said, is characterized by the coexistence of inflammation, so lobular inflammation and hepatocyte ballooning, plus steatosis, so what we call fatty liver. And this gives you the diagnosis of NASH. However, the most important prognosticator for NASH is actually fibrosis. Fibrosis, which means scarring that develops and builds up during the years because of the chronic inflammation that is present into the liver. So NASH, the diagnosis is given by the presence of steatosis inflammation. The prognosis of NASH is given by the presence of and the stage of fibrosis. However, it's important to be reminded that the diagnosis of NASH itself remains a histologic diagnosis. So basically, liver biopsy is essential for NASH diagnosis yet at today, because we don't have yet good and reliable biomarkers of inflammation and of ballooning, which are important components for the diagnosis of NASH. However, we will see together shortly that we have instead good non-invasive tests to look for fibrosis and for cirrhosis. So why we look for fibrosis? This study that has now been quoted almost 1,000 times since 2017, and that my team has participated as co-authorship, basically we looked at, as a systematic review and meta-analysis of studies, histologic studies, looking at the mortality risk increase according to the fibrosis stage. And as you can see here, one important concept that again underlines the concept of NASH and NAFLD as a multi-system disease, basically it showed that even with the stage 1 fibrosis, which is the basically fibrosis is stage from 0 to 4, where 4 is cirrhosis, you can see here that even with the stage 1, you can actually have an increased mortality rate, which then increase progressively with stage 2, stage 3, and stage 4. So even one-stage fibrosis can increase all-cause mortality in patients with NAFLD, while for liver-related mortality, you need at least a stage 2, that is what we call significant liver fibrosis, to have a significant increase in mortality related to the liver, which then actually will increase exponentially going to stage 4, which is, as I said, liver cirrhosis. So mortality really is very dependent, both liver-related mortality and all-cause mortality is very dependent by the stage of liver diseases. And that's why we need to identify patients with fibrosis, those patients with NAFLD with fibrosis. Unfortunately, one of the questions that often I receive when I do presentation on NAFLD is it liver transaminases enough? Unfortunately, they are not enough to exclude NASH or even fibrosis. In the Dallas Heart Study, where it was used MR spectroscopy to assess liver fat in a significant number of patients, actually, first of all, they found that patients with the steatosis, with hepatic steatosis, almost 80% of them had normal ALT. And even going beyond that, so we know from several studies that persistent elevation of the liver transaminases, here specifically ALT, it is true that it can be associated with progression of the disease. However, patients with normal ALT can also, even persistent normal ALT, can also develop a progressive disease. And 20% of patients with advanced liver fibrosis have persistently normal transaminases. So you cannot even exclude advanced liver fibrosis, stage 3 or stage 4, only based on the transaminases. So this is not a tool that we can use to rule out the presence of fibrosis in these patients. Are there other clinical tools, clinical indicators that we can use? Certainly they are. We said previously during the pathogenesis section of this lecture that type 2 diabetes is the most important predictor of advanced liver fibrosis with an odds ratio of 18, basically, compared to other characteristics. So high degrees of suspicion of advanced liver fibrosis in a patient with type 2 diabetes, followed also by other characteristics of the metabolic syndrome, such as obesity, combine the presence of multiple metabolic risk factors, but also, for example, older age, Hispanic ethnicity. We spoke before about these patients being at high risk for NASH and fibrosis, for example. But this is not enough in clinical practice, really, if we want to be more precise in the diagnosis. So there are several non-invasive tests nowadays available to identify patients with hepatic steatosis and with liver fibrosis. Be reminded, not with NASH. NASH is a histologic diagnosis. However, these tests are good, especially if we want to identify patients with advanced fibrosis, which we have seen is the most important prognostic predictor in the condition of NAFLD. So in terms of the non-invasive tests that are available in our tools, we have two main classes. One are serum biomarkers based on clinically or laboratory scores, usually a combination of the two, and imaging. So among the biomarkers, the one that we use the most, and we use usually in our clinical practice in hepatology, is the fibrosis 4, also called FIB4, NAFLD fibrosis score, AST to platelet ratio index. While for the imaging ones, we have at our disposal, as all of you know, at MUHC, the FibroScan, which is actually a measure of the liver stiffness as a surrogate of fibrosis, and the CAP, which is a software inside the FibroScan machine, basically, which also provides you a grading of hepatic steatosis. And we have also starting having some other elastographic technique like the FibroScan. And basically, if you see here, one of the easiest tools to use in clinical practice is actually this Fibrosis 4 or FIB4. This is widely used now in several models of care and also recommended by the consensus NAFLD, the models of care that Nadia mentioned initially when she introduced me kindly. The FIB4 is based on 4 very simple parameters in clinical practice, which are age, AST, ALT, and platelet counts. So basically when, and this can be easily found in Google, there is med calculator, it's very easy to calculate, just to input the four data. Then when the FIB4 is less than 1.3, basically the negative predictive value to rule out advanced fibrosis is 95%, which is really good for a non-invasive test such simple. The positive predictive value is not as good, so mostly we use the FIB4 in clinical practice to rule out presence of advanced liver fibrosis. When the FIB4 is less than 1.3, this indicates there is no advanced fibrosis, and a secondary, for example, diagnostic tool like a FibroScan or a liver biopsy is not needed. So what about the guidelines regarding this very important topic? Are there some indications as to which we should actually screen patients for NAFLD, for NASH, for fibrosis? This is a very relevant topic in these months. Actually, there is a lot of discussion about that. So for the moment, what is really important to look for in at-risk populations is fibrosis. We don't screen for NAFLD, we don't screen for NASH, but in some specific populations, the guidelines, especially the American Diabetes Association and the European Association for the Study of the Liver that you see here, they actually recommend more than screening. I like to use the case finding word. So case finding of advanced liver fibrosis cases in patients with type 2 diabetes or in patients with multiple characteristics of the metabolic syndrome. Of note, even the European AIDS Clinical Society guidelines, of which I am panel member, also recommend screening for advanced liver fibrosis in people living with HIV. So there is more and more a movement towards screening, case finding, better, I like, for advanced fibrosis in at-risk population. So why we actually do this case finding, how we do it? First of all, if we take the general population, and you see here the general population, out of 20 of these patients, basically, or the general population, or out of 20 people in the general population, there will be a prevalence of 25% of NAFLD, right? And among these, for the data that we have seen before on the natural history of the disease, we will actually find one of these. So 20% out of the 25% will have advanced liver fibrosis. So the prevalence of advanced liver fibrosis in the general population is actually relatively low. So there is a high prevalence of NAFLD, but the prevalence of advanced liver fibrosis in non-tertiary cohorts is really low. So it's very easy to calculate the FIB4, and if there is any suspicion, if it's negative, less than 1.3, this is very likely that there will be no problem for this patient. However, if we move to the at-risk populations, the ones that are mentioned by the guidelines that we have seen together, the situation really changes. So the prevalence of NAFLD in patients with type 2 diabetes from a 25% actually jumps to a 60–70%. So already the prevalence of NAFLD is much higher. And then among those patients with NAFLD, even the prevalence of advanced liver fibrosis is much higher. So it's probably 3 to 4 times higher than in the general population. As such, and as we said before, there should be high suspicion of advanced liver fibrosis in patients with NAFLD and look for advanced fibrosis, at least by a FIB4, which is very easy to calculate. And in this sense, Canada, some of the Canadian centers, for example, this publication comes from Edmonton, but there is also a very nice similar pathways in Calgary by Mark Svein. Actually, they use the FIB4 as a triage tool to rule out the presence of advanced liver fibrosis or to rule out the need for subsequent tests, basically. So in this publication from Edmonton, FIB4 was used as the first line test, where most of the patients fall into this low risk of advanced fibrosis, so just managed by primary care provider. In those where the FIB4 was not less than 1.30, in this case, there is a need to perform a FibroScan, and then a subset of patients with elevated FibroScan will be referred to the hepatology clinics. And basically using this 4 two-step strategy, 4% only of the patients were referred for hepatology consultation, obviously saving a lot of burden and a lot of waiting list. So from the diagnostic principles of the condition, now we will move to the therapy. So one of the main questions or comments that I receive when I do presentation on NAFLD is there is no need to diagnose NAFLD, NASH, or because there is no treatment. Well, this is really false, and there is false for 3 reasons. One, it's not true that there is no treatment approach. Actually, there are treatment approaches. Number 2, it's important, as per stated by the guidelines that we saw together, to have a cardiovascular risk stratification, at least with the risk factors in these patients. And third, if there is advanced liver fibrosis or cirrhosis, actually the clinical management change because these patients will need to be followed for surveillance of complications of liver cirrhosis, and namely hepatocellular carcinoma and esophageal varices. So let's move to the therapeutic approaches for this condition. The therapeutic approach is, in terms of non-pharmacological approaches, is basically based on weight loss. And weight loss should be achieved, according to the guidelines, by a combination of hypocaloric diet and exercise. According to the guidelines of the European Association for the Study of the Liver, energy deficit daily of 500 to 1000 kilocalories associated with regular exercise targeting 150 to 200 minutes per week of moderate intensity aerobic exercise. So it is very interesting that when you speak to a patient about a potential benefit of fibrosis, even regression based on the weight loss, you may have maybe 20% of the patients which will achieve the target. It's not a lot, and most of the literature report 15% of patients which will achieve the targeted weight loss and maintain the targeted weight loss. But 15–20% is not nothing. It's a significant proportion. So non-pharmacological approaches are the cornerstone of the approach of treatment to all patients with NAFLD NASH. And if you see here, in fact, if a patient loses more than 5% of their body weight, they will reduce inflammation and ballooning, which are characteristic of NASH. If they lose more than 7% of the body weight, they will actually resolve NASH. And importantly, if they lose more than 10% of their body weight, there will be actually regression of liver fibrosis. And as fibrosis drives the prognosis of this condition, we will have improved prognosis for these patients. So very important to underline this to patients. And how we can achieve this? So is there any regimen that is specifically recommended to these patients? Well, there are more and more evidences that the Mediterranean diet, it's something that can really change and affect positively the dietary situation of these patients. And the Mediterranean diet pyramid is high in monounsaturated omega-3, omega-6 fatty acids, is very high in polyphenols, dietary fibers, plant proteins, and water is a drink of choice. Soda drinks are the worst for patients with NASH or fibrosis. It's low in saturated and trans fat, animal proteins, and simple sugars. And one of the main components of the Mediterranean diet is olive oil. This could adapt it to by other cultures, usually the Mediterranean diet, but extra virgin olive oil seems an important component in this specific setting. So of course, I'm very happy because being Italian, the Mediterranean diet is very important to me, very dear to me. So if you see here, in terms of the meta-analysis, that I've actually produced this slide, as I said, for CCO, for clinical care options, and I was very interested in finding there are several studies already looking at the association between Mediterranean diet and NAFLD, and basically there was an inverse association between MD and NAFLD in observational studies. In trials, the effectiveness of MD was significant for steatosis when examined by MR spectroscopy, although not by ultrasound, but ultrasound is not as sensitive as Hermes spectroscopy to measure fat into the liver. And there was also significant decrease in BMI, triglycerides, and so on, although there was no significant effect on other characteristics, but there was an effect on fat. And this study, which I think it's a great study conducted in a single center in Israel, it was a randomized open label trial of 18 months lifestyle intervention in patients with abdominal obesity, dyslipidemia, via either Mediterranean diet, even stronger, like a Superman Mediterranean diet, which they call the Green Mediterranean diet, or Eltari dietary guidelines. And basically, the Green Mediterranean diet was further enriched in food that was containing polyphenols. And as you can see here, the primary outcome was the weight change and change in intrahepatic fat measures at the MRI PDFF 18 months. And if you can see here, the weight change was similar between the Mediterranean diet and the Green Mediterranean diet. However, for intrahepatic fat, there was a much higher, even much more decrease in the intrahepatic fat with the Green Mediterranean diet compared to the Mediterranean diet. So very, very, very interesting study, again, confirming the positive effects of Mediterranean diet, basically. What about other kind of diets? In this meta-analysis of low carbohydrate diets in NAFLD, 10 international clinical trials were included for patients with NAFLD, some evaluating transaminases and only 4 evaluating intrahepatic lipid content. The results showing that low carbohydrate diets were associated with significant reduction in the intrahepatic lipid content. So there is an effect also for low carbohydrate diets, although there was no significant reduction in the liver transaminases. And finally, is exercise also able to help the liver by itself? According to this meta-analysis of 28 randomized trials, actually even the exercise itself is able to significantly reduce intrahepatic lipid content and ALT, so steatosis and also transaminases, although there is not known if there is then an effect on fibrosis without the weight loss associated with diet. In terms, again, of dietary recommendation, one of the things that we usually say to our patients is to continue to drink coffee, because coffee, according to meta-analysis, seems protective not only against NAFLD, but also against liver fibrosis. And now we move to the final part of the presentation, speaking about pharmacotherapy in NAFLD. So according to the guidelines, and this is across all the guidelines for the study of the liver, American Association, European Association, and Asia Pacific Association, only patients with NASH and significant fibrosis should actually receive pharmacotherapy in NAFLD, or those with NASH and less severe disease, but a high risk of progression. For example, patients with type 2 diabetes, patients with metabolic syndrome, persistent elevated ALT, or high necroinflammation on the histology report. So in this table that I developed, basically, you can see an overview of the pharmacotherapy in the guidelines for NAFLD. You see that in all of them, but Asian Pacific, vitamin E is actually recommended as the first-line treatment in patients with NASH, basically. Pioglitazone is also recommended as a first-line treatment in patients with NASH, while metformin is not recommended as a treatment for NASH. Statin is also not recommended as a treatment for NASH, as it is not recommended the use of omega-3 fatty acids. GLP-1 agonists, further data needed. Obeticholic acid is another molecule in FXR that we actually use for the treatment of the primary biliary cholangitis, has also been shown important effects in NASH, but further data needed according to the guidelines. So let's see in the details this pharmacotherapy, the ones that are recommended. Vitamin E is used at 800 units per day in the treatment of NASH. This actually has not, there have been some reports of possible increased risk of mortality, but this was not confirmed by subsequent meta-analysis. Increased risk of hemorrhagic strokes or increased risk of prostate cancer. So, and also for pioglitazone, some edema, weight gain, risk of osteoporosis. So the use of these agents overall should be personalized for selected patients with histologically confirmed NASH after careful consideration of risk-benefit ratio. And for the statins, one very important concept is that statins must be used in patients with NASH. Patients with NAFLD, in fact, are at high risk for cardiovascular mortality, as we saw before. So aggressive modification of cardiovascular risk factors should be considered in all patients with NASH. Patients with NAFLD or NASH also are not at high risk for serious liver injury from the statins. You know, sometimes we are called because there are some elevation, of course, of the liver function test from the statins, but the statins should be used and can be used to treat dyslipidemia. So they are not a treatment for NASH, but they are a treatment for reducing cardiovascular risk linked to NASH. And in fact, there are even some recent evidences showing that statins may even lower the risk of portal hypertension in liver cirrhosis. So statins are really benefit in these patients. What about some anti-diabetic medications, especially those with the need to address body weight? We know that the American Diabetes Association recommends GLP-1 receptor agonists with efficacy for weight loss or SGLT2 inhibitors. Some of these may also have benefit in NAFLD indeed. And here, these are the results of the phase 2 of the semaglutide for treatment of NASH with a primary endpoint on 72 weeks. This was a randomized, double-blind, multi-center phase 2 trial in adults with BMI more than 25 and biopsy-proven NASH. And basically, the primary endpoint of NASH resolution with no fibrosis worsening was met. So this is a very promising molecule for the treatment of NASH, and the phase 3 is actually ongoing, and we are one of the centers in Canada to having this phase 3 study. And what about SGLT2 inhibitors in NAFLD? They have effect for sure on liver fat and ALT. The E-lift was actually using empagliflozin versus standard diabetes treatment, and it showed a reduction in liver fat measured by MRI-PDFF. So very interesting also this molecule. So overall, the approaches for the currently available treatments for this condition include weight loss, treat type 2 diabetes, targeting also cardiovascular risk factor, and there are also some liver-directed treatments that for the moment are only vitamin E and pioglitazone, but there are many global clinical trials ongoing now to identify and study and finally approve other antifibrotic treatments for NASH in NAFLD. So in summary, NAFLD is the most frequent liver disease at the global level. Liver fibrosis is the main prognostic factors in patients with NAFLD. NAFLD is a multi-system disease, so it has to be addressed, especially in more advanced stages, by multi-stakeholders, and especially it is associated with high cardiovascular risk, and also type 2 diabetes is the main risk factor for NASH, liver fibrosis and cirrhosis. So high degree of suspicion of advanced liver fibrosis in patients with type 2 diabetes. Current guidelines recommend screening, I like more the case finding, for advanced liver fibrosis, cirrhosis in patients with type 2 diabetes and metabolic syndrome, and also people with HIV. Non-invasive diagnostic tools, including the FIB4 and also the FibroScan that we have seen together, can help implementation of case finding for advanced liver fibrosis. Current approaches include lifestyle and some pharmacological options. New antifibrotic treatments that we are hope to see very soon in the future include the GLP-1 agonists, obeticholic acid, SGLT2, and other molecules are currently investigating. So I would like really to thank you. We are actually, as we are going to have a Canadian liver meeting soon where I'm chairing the CAN-NASH symposium. So anyone interested in parting deep in this topic is very welcome to attend. I would like really to thank everyone for the kind attention and for the invitation, Nadia, in the Department of Medicine.
Thank you very much, Dr. Giada Sebastiani. Fantastic, really, really exciting. And I think, a great presentation for Department of Medicine, because we all recognized ourselves as we all recognize some of our patients in this presentation. Whether you're talking about diabetes or cardiovascular and all kinds of other complications that had come along, or comorbidities that come along with this disease. First of all, congratulations, really terrific work in this area, and putting McGill on the map, in this fascinating field. So congratulations on all the work that you have done. We have questions coming in. We have great comments. Coming in, and I'll let you read some of the really, really nice comments. Dr. Dasgupta wants to work with you, and that says a lot, right away there.
Very. We're already working together. There
you go. It looks like she wants to work together, so I'll let you read that. Dr. Grover is, stated great presentation, and he's talking a little bit about LDL, and I guess Stephen Grover is, has been around for a few years, and he remembers when we first started using LDLs, statins to lower LDLs, and now they, and we had to also use, obviously, adjust our diets. But he's asking if you worry that we are setting up NASH patients for failure with lifestyle changes like weight loss, that few will succeed, and that perhaps we have to be more aggressive and sort of treat everybody. I guess his question is really about, can weight loss really be enough, and lifestyle changes really be enough?
Yeah, no, I think it's a great question. So unfortunately, I don't think that lifestyle changes can be enough for most of the patients. It can be enough for a subgroup of patients. And in the literature, it's actually reported about 15% of the patients with NASH are achieving the targeted weight loss. So the question that very nice of Dr. Grover is what we do with the other 85%. So that is why I think his comments on targeting aggressively, for example, at least the cardiovascular risk and the lipid, this is very important to do in all patients. The cornerstone of treatment for all patients with NASH and NAFLD remain lifestyle modifications, but this is, I think, for most of the patients is not enough. So the other 85%, when you have others, you can't, they cannot achieve the weight loss. There is also a small percentage of patients which will also undergo bariatric surgery, for example, when there is an indication. But overall, there is really a need for these antifibrotic molecules that there is now, there is a run, like for the gold in the West at the time for this, to find safe and effective medications beyond the lifestyle modifications.
Fantastic. So Dr. Kimoff, as you know from RESP, wants to make sure we don't forget the RESP patients in this whole body of literature. So he says there is some literature on sleep apnea and nocturnal hypoxemia to increase risk of steatohepatitis in NAFLD. Basically, the bottom line are, what is the role of OSA in NAFLD?
Yes, no, this is very important concept, and this really goes again. OSA was actually one of the extrahepatic manifestations that it was listed in my presentation in that rows of extrahepatic components of NAFLD. So there is, I think that the link between OSA and NAFLD is also bidirectional, like the diabetes that we have seen. It's less known with respect to diabetes, but we know that patients with NASH, they are actually at high risk of develop obstructive sleep apnea. And on the other side, patients with obstructive sleep apnea are at high risk for develop NAFLD and NASH. So there is a clear pathogenetic link between the two conditions, which is less known and less studies, especially in terms of what this implies for the prognosis of the disease, as it is for diabetes, that we know much better data in terms of natural history. But I think this is an area of study that is still needs to be addressed. Thank you for the comment.
Thank you. Question: How do you suggest we screen patients with Fib4? How often? Should we be screening everyone on a regular basis? Can you tell us more about that?
Yes, this is another great question. So according to the guidelines, the Fib4 in patients who don't have, where it was negative, the Fib4 can be repeated every 2 years, basically. Every couple of years, you can repeat the Fib4. If you have instead a patient where the Fib4 was more than 1.30, then you should get a FibroScan, basically. And now at the pathology division, in our division, actually, we are using this kind of triage. So usually we ask for a Fib4, and if the Fib4 is more than 1.30, we schedule and we book the patient for a FibroScan. For the Fib4, usually the recommendation is to do every couple of years.
Fantastic. Should patients with fatty liver avoid alcohol? What about acetaminophen?
Yes, Sasha, thank you for the question. And I also read your comment on over 50 advanced. I know. So advanced age is really in the concept of the life span of the liver, I think. But I get your point. I got other times that comment. Anyway, for the alcohol, I mean, it's a very tricky question and very good one. Until 3-4 years ago, there were some studies showing that a mild consumption of alcohol could actually be, in patients with NAFLD, could actually be associated with the lower stages of fibrosis. However, this concept that is a little bit falling into decay because of after that Lancet Public Health publication of a couple of years ago, where alcohol was associated with the all-cause mortality in any section and in any disease. So for the moment, I am very strict on no alcohol intake in patients who have advanced liver fibrosis. That it's really even carcinogenic, even more in patients with advanced fibrosis. In those who have early NASH, it would be a general recommendation not to drink, but not as really firm and strict as in patients with advanced fibrosis or cirrhosis. Thank you for the question.
And for acetaminophen, can you just tell us a bit more about it? So just let me actually just go back to another question here. If the FibroScan is negative after Fib4 over 1.3, do you still do the you continue to repeat at some point down the line this FibroScan, or is just one enough?
Very good question. If the FibroScan is negative when you have done the Fib4, actually the positive predictive value of a Fib4 over 1.3 is not very high. So if the FibroScan is negative, you can just repeat the FIB4 after 1 year. Maybe you can repeat after 1 year instead of 2 years. If the FIB4 instead is more than 2.67, which is that value that we found that I showed you in the table with the positive predictive value of 75, maybe it's better actually to repeat the FibroScan 1 year after to make sure that it's really negative. If it's more than 2.67, this is what I would do actually for my patients. But if it's just 1.30 and less than 2.67, just repeat the FIB4. You don't need to have another FibroScan.
Just we have maybe 2 minutes left. I'm going to try to get through just quickly. Can the fibrosis be detected on CT abdomen, and should we be using semaglutide to treat?
Let's see.
CT abdomen. Can you detect fibrosis on the CT abdomen?
Oh, no, not really, actually. I mean, fibrosis, mostly cirrhosis. You can see cirrhosis in a C abdomen because it's really the morphology of the liver. But to see a stage 2 fibrosis on a CT, not really. It's not recommended, no. Cirrhosis, you can see it, but because it's morphological, you see it, but fibrosis, no. Yeah, and then the other question, sorry, it was, should we using semaglutide, right?
That's correct, so yeah.
That's a very good point. As I was telling, guideline specifically to NASH recommend that we need more data, further data are needed. However, I have to say that in the last liver meeting of the American Association for the Study of the Liver that was held in November 2021, there were more voices towards the fact that if you have to start a patient who you know has NASH on an anti-diabetic, you may prefer, especially if there is a need for weight loss, you may prefer a semaglutide, maybe, yeah. There were some, opinions on that, although I need to wait for the phase 3 data, yeah.
Giada, thank you so much. We're gonna have to stop the questions there, but I invite you, if you can just maybe answer the questions directly in the chat, and I invite you to look at the chats and some really great comments coming in. Congratulations on all the work you've done, and really thank you for the fascinating presentation. Really, really a pleasure to have you here today. Thanks everyone for joining us. And those of you who have questions that are unanswered, please stay online. And Giada, if you could just answer them in the chat, that would be wonderful. Thank you so much, everyone. Thank you. Have a great day.
Thank you. Bye-bye. Thank you for having me, everyone. Thank you.
Bye-bye.